WHO identified the second challenge it took up in patient safety was surgical safety. And in this context, it becomes relevant that more than 300 million surgeries are carried all over the world today. And India, with its big population, contributes significantly to this number. However, looking at demographic of Indian population, almost 30% of them are below poverty line and 70% in the rural area. And their first point of contact to the health sector are the government institutions. The moment we say government institution, the picture which comes up are big buildings, dirty linen lying here and there, foul-smelling wards and corridors, patient being abused, etc. There are a lot of reasons for this, which over a period of time has been overcome with good funding coming up from central and state governments, awareness being created among the healthcare workers. And towards this end, I would like to today share with you the effort of a small department of pediatric surgery in a vast jungle of Bangalore Medical College and affiliated hospitals, how we tried to put in place the standard WHO protocol to try to see whether we could achieve patient safety. The WHO vision was to have safe surgery, and it found that almost 50% of surgery-associated morbidities were preventable if proper protocols are in place. This was achieved by focusing on 4 points: safe anesthesia related to available technology and anesthesia manpower, prevention of surgical site infection by using appropriate antibiotic cover and also good tissue handling, safe surgical teams who would prepare for the surgery, have proper discussion, plan out the surgery, have good communication skill within the team, and measuring the surgical outcomes repeatedly, auditing them and trying to learn from them and improvise based on what was the result. The background of that was the last 2.5 years where the Department of Pediatric Surgery shifted to a super specialty block where we got some funding and we were able to start off with this establishing safe program as per the WHO protocol. The goal was to establish safe surgical procedures and patient safety in spite of having constraint in manpower, funding, and most important of all, attitudes among healthcare workers. The amount of surgical load is more than 1,500 per year, and this is catering exclusively to vulnerable population, the pediatric patients, significant component of whom are infants and neonates with their own high-risk factors. By putting in place pre, peri, and post-operative protocols, we were able to achieve a smooth transition from admission of patient to discharge without any major morbidity in a significant number of patients, and the surgical associated morbidity came down compared to what was happening earlier. How we started off was, in the pre-operative period, we went on to standard surgical planning, treatment planning discussions. In the morning, Dr. Anupam Sibal put up a case about wrong site. Another issue when sometimes you have wrong site or wrong site is where you misinterpret radiological pictures. Sometimes some of them are labeled left and right in a different way, anterior-posterior, some of them in the posterior-anterior. So these are all things which are sorted out during the treatment planning. Then the parents are counseled. We have a standard form where everything is explained to them and informed consent taken by them in the language they know. So you have the standard local language as well as in English. Arrangement of blood if anticipated blood loss is more than the required or permissible blood loss. The patients are then sent to the anesthetist team who go through an exhaustive pre-anesthesia checkup, preparing themselves for the surgery a day before. Surgical site and site of marking is a part of any bilateral organ surgery. In the theater, they have a WHO checklist which is followed: pre-induction, pre-incision, and pre-closure. Surgical the standard dry mouth form which is done, and which at the end of the procedure is signed by the technician, the nurse, the anesthetist, and the surgeon. The anesthesia is managed by a team of anesthetists, from a senior anesthetist to the registrar, who are quite efficient and have backup monitoring, which is capable of monitoring pulse oximetry, ECG, blood pressure, and EtCO2, which is a standard recommendation as per the WHO safe surgery requirement for safe anesthesia. Before starting the incision, during the timeout, it's made sure that appropriate use of prophylactic antibiotic as per the organ which is being operated, 30 to 60 minutes before the incision. Use of central lines, arterial lines, and catheters where the surgery is going to be a major surgery or in appropriately required situations. Fluid warmers and patient warmers in vulnerable groups like newborns and infants, where we expect temperature loss and hypothermia being one of the major contributors to surgical morbidity and post-operative recovery. Proper preparation using using appropriate hand scrub techniques, using appropriate antiseptic preparation of the part, and making sure that sterilized instruments are used. It can be an autoclaved instrument, or it can be a etio-sterilized instrument. Tissue trauma or inappropriate handling of tissue is supposed to be a major contributor to increased surgical site infections. This is taken care of by compulsory using of magnifying loops in infant and newborn surgeries or in high precision surgeries, and by having appropriate instruments, fine instrument, to take care that there's not much of tissue mishandling. Frozen section backup, and before closure, going through the checklist again to make sure there are no loss of counts of instruments and mops and swabs. After the surgery, the patients are shifted to the post-op recovery ward, monitored by the nurses and anesthetists, and then shifted to the ward once the anesthetists are convinced that the recovery is appropriate and adequate. Major surgical patients, newborn patients, are directly shifted to the respective neonatal surgical or pediatric surgical ICU, which are exclusively managed round the clock by trained nurses, registrars, and 24-hour faculty cover. The appropriate hardware are there, the warmers, patient warmers, infusion pumps, syringe pumps, ventilators, etc. Use of parenteral nutrition where there's indication, where there's prolonged fasting, where the gut cannot be used, using central lines, using pumps and syringes. We have a local HICC which monitors and which makes sure that the protocol is in place. Administrating antibiotics as infusions in newborns, which is again one of the recommendations to prevent toxicity, especially when we are looking at antibiotics like aminoglycosides and cephalosporins, penicillin derivatives, etc. Some of the other changes which were implemented were evidence-based by doing studies carried out in our own situation. The earlier antibiotic protocols, which were over a few years back, were random, prolonged use of antibiotic. And after the new protocol was set in place, we've fixed, as per the CDC and WHO guidelines, no use of antibiotic for clean cases, use of pre-operative single-shot antibiotic depending on the organ involved for clean contaminated cases, and of course remaining were culture-based or depending on the organ-based. All the residents, consultants, and nurses are mandatory go through ACLS, PALS, and NRP training. Regularly, information is entered in, and they are audited at periodic intervals. They have different forms of, we have different forms of audit. It might be a departmental morbidity mortality meeting. It might be a CPC with the Department of Pathology in the institute, and yearly statistics which is regularly updated, looked at, and presented in various fora to learn from any mistakes or any deficiencies and to correct upon them. This is an example of how the IP and OP statistics, which have shown a significant rise in numbers of both the inpatient and outpatient over the years. Similarly, the surgical numbers, significant part of our patients, pediatric surgeries are emergency surgeries and newborn surgeries. Regular data keeping, auditing, and presenting in national and state level conferences, interaction with peers, learning from any mistakes over this, presentation on publications of studies which are carried out in the department are also part of the learning process and putting processes in place. Positive outcomes are we have been able to stick to protocol. It is now almost like brushing our teeth. Most of them do that routinely, and it's followed up subsequently. The problem all of us would face would be to continue to maintain this, because there is high turnover, transfer from department to department of healthcare personnel. So this is supervised by regular training, reinforcement of the various protocols to the new entrants, and monitoring and remediation measures where required. So some of the things which we have managed to achieve are early discharges, early completion of multiple stage surgeries where early discharge plays part of the role, faster recovery, and over a period of time, we tend to focus on this, try to improvise further on this. The path is a very long one, but we have to keep walking, crossing milestone after milestone to achieve what is required for safe surgery. Thank you.